In this module, we're going to talk a little bit more about the types of problems that can occur because of coronary artery disease and some assessment discussion. The first issue is chronic ischemic heart disease. I mentioned that in the first slide. This includes stable angina, silent myocardial infarctions, and Prinzmetal angina. This is when ischemia occurs, and it's because coronary arteries fail to provide enough blood to meet the myocardial oxygen demand. So there is an occlusive process which is reducing blood supply, which leads to ischemia, and then it leads to, because of that ischemia, symptoms. The common cause, again, is atherosclerosis, and the types of ischemic heart disease include stable angina as one. So with stable angina, the underlying cause is a stable atherosclerotic lesion. And the symptoms can be precipitated by physical or emotional stress, cold exposure, activity, that sort of thing. Signs and symptoms for stable angina are common to the patient. They know what the symptoms are. They recognize them. So it might be that a person knows that if they're out walking, they can walk for about 20 minutes and then they start getting some chest pain. They sit down maybe and rest, and the pain goes away, so they can get up and they can walk a little bit further, another 15-20 minutes, and they start developing their pain. So that is stable angina. It's known to the patient. They can recognize it. They manage it the same way. Maybe it's just sitting down and resting. Maybe they need to take one nitroglycerin, and then they don't have any problems. Sometimes patients will take, they know that they're going to be active and they know that they're going to have some chest pain, so they can take their sublingual nitroglycerin prophylactically before they have activity. A silent myocardial infarction, silent myocardial ischemia, I hope I said that correctly earlier, this occurs without pain. And the reason for the lack of pain is uncertain, but it's has a higher incidence in people with diabetes related to neuropathies, most likely. Now, sometimes patients that have neuropathies, we need to make sure that they understand that this could be a problem. The third type is Prinzmetal angina, again, variant angina, and the cause of this is uncertain, but the speculation is that it's caused by vasospasm, and it occurs commonly at rest or with minimal activity and early in the morning. The diagnosis of these type problems is usually finding out about risk factors, talking to them about their pain history, getting an EKG, and oftentimes with these situations, an EKG is normal. They may do an echo as a baseline, possibly. And sometimes with these folks, it's not uncommon that they do a stress test. So they'll put the patient on an exercise stress test, and with activity, they'll watch for EKG changes that might indicate some sort of problem. Possibly they could do a cardiac catheterization or an angiogram to see if there's any occlusion. Not necessarily common. And if they drew blood work to look for cardiac biomarkers, they would be negative for these particular problems. So beyond chronic ischemic heart disease and those particular diagnoses, we will on that last slide, I went a little bit too far. So don't be concerned that you missed out on something because you didn't. So beyond the three that I've talked about, that the three problems that are under the chronic ischemic heart disease, we also have acute coronary syndrome. So acute coronary syndrome includes unstable angina and myocardial infarctions with the non-ST segment elevated myocardial infarction or an NSTEMI, and a ST segment elevated myocardial infarction or a STEMI. So the first one's an NSTEMI, second one's an STEMI. So with unstable angina, what occurs is pain-wise, the pain that a patient might have is different a little bit. It's changing. And that could indicate that that lesion, that occlusion, is progressing. So it might be that maybe their pain starts with less activity. Or maybe they can't just sit down and rest anymore, they have to take a nitroglycerin. Or instead of taking one nitroglycerin, they have to take 2 nitroglycerin tablets. So somehow that change, that it's different. Maybe now when they have their anginal pain with unstable angina, they have some associated symptoms, signs and symptoms. Maybe they've never had radiation before, but now it's radiating to their shoulder, or to their back, or to their jaw or teeth. So something is changing about that pain. Now, when we look at these issues with unstable angina, physician will also order an EKG. And on an EKG, you can see one of 3 things. And here's my QRS complex. And in this case, what we have right here is an inverted T wave. So when a person has unstable angina, one of the changes they can have is an inverted T wave. Or another symptom, another change on an EKG that they might have is ST depression. So here's the ST segment down here when it should be up here. Okay, so the ST segment should be up in this area, but it's below the baseline. That is another EKG change that can be associated with an unstable angina. Or they have, and I have no idea how to draw this, but they have non-specific ST wave changes. So one of those 3 changes can occur on an EKG or a combination. And so then they say, oh, okay, this person, something's going on here, a little bit more than stable angina. We need to get cardiac biomarkers. So they draw lab work, they draw the cardiac biomarkers, and they're negative. Now, for an NSTEMI, what you can have is the pain is going to be similar to unstable angina, but it's going to be more intense. EKG changes that you would have would be the same type EKG changes that you would for unstable angina. And when they do cardiac biomarkers, though, the cardiac biomarkers would be positive for an NSTEMI. So EKG changes, you would see this potentially the same ST changes that you do with unstable angina, but now the defining characteristic is the positive biomarkers. Now, these are usually due to occlusion of a smaller vessel or to distal portions of vessels. So it's not affecting as great an area of the myocardium. The problem is they can extend, they can get bigger. Now, an ST segment elevated myocardial infarction, or a STEMI, the assessment, the pain is more intense, and the EKG shows ST segment elevation and the development of pathologic Q waves. So for a STEMI, you might have your EKG or your QRS complex here, and ST elevation could look something like this. So here's a T wave, the top of the T, the peak of the T, but from here to here is the ST segment, and it is well above the baseline. So that is significant ST segment. Even if it was one small square elevated, that's still ST elevation. Now, pathologic Q waves may not occur immediately, but they over time with a myocardial infarction, they can occur. And what you would see before the Q wave, before the QRS complex, is with this you would have a deflection here before it goes up. So this would be with once it meets certain criteria, and I'm not going to go over those because you don't need to know that right now for our purposes, you would see this Q wave develop, pathologic Q wave, and that Q wave will always be there from that point on. So with the STEMI, we're also going to draw cardiac biomarkers, and they are going to be significantly positive. With a STEMI, the damage to the myocardium can be extensive, and it's usually due to an occlusion of a large vessel or a very more proximal lesion of a vessel. So it is reducing blood flow to a larger portion of the myocardium. So assessment. We would want to get a history from the patient, and oftentimes, especially when a person is in significant pain, we are going to delay that type of information gathering until we get some immediate interventions taken care of to try to relieve that pain and potentially reperfuse the myocardium. And the MONA, vital signs stability, pain relief, that's what we want to accomplish prior to sitting down with the patient, talking to them a little bit more about their history. But under history, we would want to know, find out what their pain is like. And it's just an overall good pain assessment, the location of the pain, the intensity, quality. Usually with myocardial pain, it's described as a squeezing type pain, a pressure-like sensation. It feels like somebody took a belt and wrapped it around my heart and they're squeezing it in on it. Feels like somebody is standing on my chest. It's not described as a sharp pain. It would be more of a dull, aching pressure type pain with myocardial pain. We want to know, does it radiate? How long does it last? Are there any associated signs and symptoms? What brought the pain on? What relieved the pain? Typically when we're talking about myocardial pain for an infarction, it could have occurred at rest. The pain occurred at rest. They weren't doing anything. For anginal pain, typically it's related to activity of some sort. We want to know their personal history. Do they have a cardiac history? Do they have other medical problems? Are they diabetic? What is their family history? What risk factors do they have? What current medications are they on, if any? And what type of lifestyle choices do they make? What's their diet? How much activity are they getting? Do they drink alcohol? What is the extent of their alcohol use? Do they smoke? And then we also want to know, have you had any prior revascularization procedures, like an angioplasty or stents or that sort of thing? Physical assessment is important too. When we're talking about pain, again, the same type things we're going to be assessing for when a patient is complaining of pain. Maybe they've been admitted to the hospital now and they complain of pain again. We can talk to them about the type of pain. What are their vital signs? What's their level of consciousness? We want to be paying attention to that. Does it change with pain in terms of vital signs? Dysrhythmias. So the patient would be on telemetry most likely when they're admitted to a cardiac unit. And we want to be monitoring for any sort of ectopy, or what is their underlying rhythm? What's their baseline rhythm? Are they having any dysrhythmias? Listening to heart and lung sounds, that's important. Looking at peripheral circulation and doing good circ and neuro checks related to that. What is their, when we're talking about vital signs, what's their SpO2? So just overall good assessments of the patient after they've been diagnosed, and this is on a continuous basis. Other assessment issues that we could do, we would want to get an EKG. And with an EKG, we want to get that, if they're coming into the emergency room, say, we want to get an EKG within 10 minutes of their arrival. We need to know what's going on. And we prefer to get an EKG with pain. Now, initially, the EKG may be non-diagnostic. So what we may end up doing is doing serial EKGs every 15 to 30 minutes for the first hour, just to see if that EKG is changing. And we're also looking for dysrhythmias that might be there. Laboratory assessment would be important, and a lipid panel could be ordered. That probably would not be ordered necessarily acutely, but at some point we would want to get an idea of what their lipid panel looks like. Cardiac biomarkers are more important for us to be aware of, and there are two different tests that can be done. Troponin I is one of the tests, and troponin I is located primarily in the myocardium, and it's released when myocardial ischemia occurs. It's a good indicator that myocardial damage has occurred. The normal levels for troponin I is less than 10 nanograms per milliliter. Now, with troponin I, the initial onset of rise is 4 to 6 hours after symptoms occur, and it peaks in 18 hours, and it's going to be elevated for 6 to 8 days. The next one is troponin T, and troponin T is also found in skeletal muscle, and it initially rises in 2 to 12 hours, peaks in 12 to 48 hours, and has a duration of up to 14 days. So troponin I is more cardiac specific. Creatine kinase is another enzyme. Creatine kinase, CPK, sometimes you'll hear it referred to as creatine phosphokinase. But creatine kinase, or CK, is found in the brain and skeletal muscle and cardiac muscle. And there are isoenzymes of creatine kinase. The enzyme that's found in brain tissue is BB, so CPK-BB. Skeletal muscle is MM, so CPK-MM. And cardiac is CPK-MB. Now with the MB, there is initial rise in 4 to 8 hours, It peaks in 12 to 24 hours, and it is duration is 2 to 3 days. So it peaks quick and returns to the baseline a little bit faster than troponin I. The normal value for CPK is less than 170 units per milliliter. Troponin levels, again, indicate myocardial necrosis earlier than CK enzymes do. Other assessment potential things would be a chest x-ray. However, usually a chest x-ray is not done unless the patient has a history of heart failure. Chest x-ray probably would not show much in terms of myocardial infarction other than enlargement of the cardiac silhouette. Exercise tolerance test or a stress test could be done in some cases, and this might involve a patient actually being on a treadmill. Now, if a patient has an MI, they're not going to do a stress test. They're not going to put them on a stress test and make them do an exercise tolerance test. They could use, if a patient, maybe a patient's doesn't have the ability to do that kind of activity, so they can do what's called a chemical stress test. So the patient is in the cardiac lab, and they use dobutamine instead of a treadmill to elevate the heart rate. So you can give the patient dobutamine and observe for any EKG changes, just like you can if they were on a treadmill. And then a coronary angiogram can be done too, and it depends that they may, in some instances, want to do an angiogram as the patient is leaving the emergency room on their way to, say, the ICU or to a cardiac unit like PCU at Harrison, to see what's going on, and then maybe they could do an angioplasty at that same time. So those would all be decisions that were made, by the physician in terms of, the cardiologist in terms of when to do it, based on the patient's presentation.